One of the reasons I love living in Alaska is because in so many ways, this vast state actually operates like a small town. But in our case, relationships and neighbors are interconnected over thousands of miles instead of just one street from the next. And so it seems appropriate that this conversation on what for many is a difficult subject is something we can share together. This presentation on palliative care is being taped here in Juneau, but will be available from Ketchikan to Barrow thanks to Alaska Public Broadcasting and the web. Juneau's Foundation for End-of-Life Care connects both healthcare professionals and the public in various ways, including education. It is our hope that through education and inspiration, we can all learn what is really important about how to live a life that is rich and full as possible. This event would not be possible without the hard work of our volunteer board of directors, as well as generous support from the Juneau Medical Society, Bartlett Regional Hospital Foundation, Alaska Capital Inn, and St. Hubert Research Group. I'd like to introduce our presenters, two amazing women who work together in Anchorage as part of Providence, Alaska Medical Center's palliative care team. Dr. Linda Smith was formerly an emergency room doctor who is board certified in palliative and hospice care and also serves on the board of Hospice of Anchorage. Deanna Seropian is a licensed palliative care counselor and social worker. Together, they'll be guiding us through everything you wanted to know about palliative care, but were afraid to ask. Please give a warm welcome to Dr. Smith and Ms. Seropian.
Wow. Thank you so much, Claire, and thank you to all of you who have come here tonight to have a discussion. Hopefully this will be a little bit more interactive than sort of didactic. We're thrilled to be here, and for all of those who are a little bit leery about sitting up front or getting too close, thank you for coming to actually engage and having a discussion about end-of-life care and advanced serious illness, and particularly palliative care. So as we go through this, do you have anything else to add to that before I get going?
Just to thank you all for taking time out of your very busy Fridays to come and join us here. It is truly a pleasure to see all of these wonderful faces.
So we thought we would just start with what we get asked a lot, which is, what is palliative care? It's a huge question, and it's actually a fairly new specialty. So if you're asking that question, you're right on board with about 99% of the rest of the population. So palliative care, actually, the word palliative is a derivative of the word palliate, which means to make easier or to lighten a burden. And so when we talk about palliative medicine, or the medical definition of palliate, I love this definition. This is from Merriam-Webster, and what I like about it is the definition that they use is, quote, to reduce the violence of a disease. And I think when you hear that definition, the word violence in me evokes an emotion. I mean, it's a strong word. And it reminds me that when people receive a diagnosis that they have a serious illness, it's not just a diagnosis, it's not a symptom, it's not like an organ, it's a whole impact on a person. And that evokes a lot of emotion, and a lot of, I guess, but I'm kind of looking for some words. Devastation, not just to the patient, but to their family and to the community in which they live. So the word violence, I think, in this particular episode is a good reminder for us. And then as we move into what is palliative care, so moving from those definitions into palliative care, this is an emerging, meaning brand new, since really about 2006, this has been a specialty board. So that's very unusual for medicine to create a whole nother specialty. So only since 2006 has this been boarded, and we are now emerging out into the population to help serve our communities, including our physician, nurse practitioner, mid-level, nursing, all healthcare providers, to help improve the overall quality of life for people and their families who are experiencing serious illness.
And being that we are so new, it means that every time we come into a patient's room, the first thing we need to do is pretty much explain who we are, what we do, what is this thing called palliative care. So there's a whole learning process related to this.
So what do we do? Why do we get consulted? Who calls palliative care and why? Well, the first and easiest thing that I can say to you is that we do symptom management. Probably about 50% of the outpatients that I see, I'm asked to manage their symptoms, and most of that has to do with pain. Patients who have very difficult to control pain, nausea, vomiting, diarrhea, those kinds of symptoms that go along with some illness and treatments that we actually do to patients as well. But in addition to that, there are lots of other symptoms.
However, I would also like to point out that even though Linda is saying the easiest that we do, it is a very difficult specialty that many times regular care providers are not as familiar with on how to treat pain, how to treat nausea, these symptoms that are really affecting quality of life. And that is where palliative care medical providers really come in and make a huge difference in patients' lives.
And sometimes patients just don't respond to traditional treatments. So you may be treating their nausea and vomiting, but they just can't get it under control. And so we're sort of that next step beyond in symptom management. We're also often asked to come in and help facilitate difficult discussions with patients and families. I was just talking with someone before this started tonight who was saying that even though her father was dying, she was meeting with her brother and her father, and her brother just couldn't get there. He just couldn't fathom that his dad might be passing. And so he just couldn't even have the discussion. And yet the patient's clearly not doing well, and one of the children is ready to talk about this. How do you manage that situation when someone just won't talk about it, but you need to have this discussion? So we have ways and techniques that we help to facilitate those kinds of discussions with families.
And medical providers nowadays are physicians and medical professionals are usually trained to heal, to fix, to cure. And when the point comes when that is not an option or no longer a possibility, most physicians or medical providers have not been taught how to have these discussions. They also oftentimes do not have the luxury of the time, or think they do not have the luxury of the time to sit down and have these discussions. And oftentimes it is also heartbreaking for these providers to have these discussions. An oncologist who has treated their patient for years, trying to save their lives, coming to the end of that road, it's really, really hard for them to sit down with the patient, the family, and have that hard discussion. And that oftentimes is when we get called in to assist also the providers, to be that linkage.
Yeah, that shift from curative intent to suddenly, wow, we can't cure this, so now what do we do? And quite frankly, I've been in medicine for 20 plus years, and until I did the palliative care fellowship, I thought I knew exactly how to have these conversations, and I really didn't know, and they're difficult. And each person, each family is really unique, and so trying to figure out how to get in there and have really good, meaningful conversations for physicians who have not had this training is really difficult, and often fractures families, not intentionally, but because they just don't know what to say or how to say it. So we're still learning. I'm not saying I'm perfect, but I am saying it's tough, and it is a skill set. So one of the things we do talk about a good bit is goals of care. So you'll hear that term thrown around probably in the near future as people begin to talk more about goals of care or advanced directives. And what that really is in the past, physicians have been very paternalistic. We've walked into the room, we've said this is the problem, this is what we do, and we expect our patients to do that. There's a shift right now in our culture where people are really actually asking great questions, and the goals of care discussion is driven by the family. What is important to them? It's not just the physician being paternalistic or healthcare provider being paternalistic. It's the family really engaging and saying what is important to them and establishing what their goals are, not what our goals are for the treatment team.
In our medical system, we have made such incredible advances and such technological discoveries. We can do so many things. The question sometimes is, should we do all that we can do at all times? Goals of care, really important piece of discussion to really look at, is this something that should be done? Is this something the patient would want? Would the family want this? Are we meeting, whose goals are we meeting? Who are we treating?
So in addition to that, we do an awful lot of patient and family support. So our team will talk more about how we do team approach to care in the future here in a few slides. We do a lot of support for patients, families, and for staff that is caring for patients throughout their illness. We have counselors that do grief and adjustment work. I'll let you talk a little about that.
And at the same time, it is also really not something that we delineate, because when Linda meets with a patient, there's always, the support piece is always part of palliative care, whether it's the physician or the counselor or the social worker. We're all providing that support piece at the same time. It's really not something that we can parcel out. But when patients are diagnosed or experiencing life-altering illness, everything changes. Their entire lives get turned upside down. Their families change. When a person becomes a patient, the family becomes caregivers. All the roles shift. So it is really, for all people, a huge adjustment. And palliative care tries to walk alongside and tries to support the patient and the family in the entire journey. Grief. Grief comes with that, of course. There's so many losses. Even if the illness is not terminal, even if the person is not facing death, there are oftentimes losses that come with having a life-altering illness. Maybe a person can no longer work. How important is work to our lives, right? It's our role, it's what we do, what we identify ourselves with. So having to give up our livelihood, in addition to all the financial issues it brings up, just the grief of losing the roles we have. So much adjustment needing to take place so that we can find our new way of being that envelops and encompasses the medical condition, so that we find our new way of being. And our hope and our goal as palliative care is to be those folks alongside that can help and guide and help assist in this adjustment period.
And then finally we do advanced care planning, and this is another term that you'll see later on in some slides. But we actually open that door to discussions that our culture and our society is so reluctant to have. Sort of like, what would we want to have done if something happened to us? What we want to have done to our bodies? What plays a role here? Is it my spiritual background, my values, my family? What makes me make these decisions, and how do I make them? And how do I write them down? How do I pick a power of attorney? How do I make a will? How do I do advanced directives to say what I want to have happen to my body? These are all discussions that are really difficult to have for people, and yet there's pretty relatively easy ways to open those doors to the discussions. And what we find so often is this taboo that we feel about having these discussions. As soon as we just open the door, it's like people go, yeah, and they just open the door because they've been wanting to have these discussions. They just don't know how, and no one's actually offered the platform to have the discussion. So that's a lot of what we do also, which is just what we call advanced care planning. This is actually our next slide to kind of lighten things up a little bit. And you know, my friends say, can't we talk about something a little more pleasant? And so we put this in here to sort of break things up a little bit. And this is, I'll let you talk about Roz.
It's just a fabulous book that I don't know, some of you might know. It's won some prizes last year. It's just a fabulous book. Rose Chast is the cartoonist for the New York Times. And she had these lovely parents in the mid-90s and had a long, long journey with guiding her parents along the difficult road. And so she wrote a memoir of this in cartoons. And this book it's heartbreaking, it's hilarious, and it is just a wonderful read. So we heartily recommend it.
Yes, we do. Absolutely. All right, so why do we need to talk about this? I mean, this is sort of a, can't we talk about something else more pleasant, and why do we need to talk about this? And so I'll tell you that I believe, and if you look at the statistics right now, our population is changing. You know, this baby boomer generation that's coming of age, that we're beginning to look at our retirement, this bolus of people is heading into retirement. We're living longer than we ever have before. Our average age of life right now is 78 years old, okay? 78. So people are going to be entering retirement, at 65 or earlier if you could, but most around 65 and living another 13 years beyond that. So we have a large population of people who are aging. This population of people is highly educated. Our baby boomers, we have instant access to internet, right? I mean, people used to come into the ER and say, I have appendicitis. I read it on the internet, So this is a very educated group of people, and they're asking really good and strategic questions. So this population is going to live longer. The 60 is the new 40. So they expect at 60, 70, 80s to be functional, highly functional. So they're demanding better care than they ever have. And at the same time that we've got this aging population in place, we have huge advances in medical care, right? We've had the onset of antibiotics that have boosted the length of our lives tremendously. We've had vaccines that have boosted our lives. We've had all sorts of pharmaceutical improvements so that patients that had, say, a diagnosis of ovarian cancer just a decade or 2 decades ago, it was pretty much a death sentence. You had a year or 2 at most, and now we're seeing people live 5, 10, and 15 years. So people are living longer with chronic illness. And our state actually boasts the best mortality rate for our neonatal population, which is fabulous. That means we have great neonatal care. But that also means now that we have a whole population of neonates who will be living with long, chronic, serious illnesses, and we'll need to find some way to take care of them as well.
This is the pie slide. So as our medical system has advanced, one thing that has happened, as we all know, is that the specialtyization has increased tremendously. So now we have pretty much a specialty for everything. And if you are a patient entering a hospital with just a moderately complicated medical condition, you will most likely have a kidney specialist, a liver specialist, depending on what your conditions are. So you might have all these different specialists, each of them most likely spectacular in their specialty, and each of them viewing you most likely as just that little piece of their specialty, viewing you as the liver, the kidney, the heart, and sometimes not really good at communicating with each other and not really good at communicating with you, the patient, who is a whole person. So what our patients oftentimes experience is just feeling like they're just being sliced up in these little slices, and nobody really provides the whole picture. Nobody really looks at the whole you, the whole me, the whole person. So what we do as palliative care is we try to come in, and this is why palliative care is really such an amazing specialty, especially for the medical providers, because they really communicate with all these different specialists, gather all that information, and try to make a cohesive knowledge for the patient, so that the patient really gets the whole picture and is being viewed as the whole person. So that's the pie.
Someday when I get really good, I'm going to learn how to make that guy turn around and put the piece back in the pie, but I can't get there yet. So, also I think why are we having these discussions is not just our population change and our changes in technology and medicine, but in the news, everywhere you look, almost everywhere you look now, you're going to see something, especially if you're in our field, you see it everywhere. But the Institute of Medicine just put out a report on end-of-life care in America, or dying in America is what it's called. And boy, there are an awful lot of things in that report that says we don't really do that great a job here. We really need to educate our physicians, our nurses, our mid-levels, all across our healthcare system. We need to empower people to begin to ask questions. It's a long read, and if anybody needs some nighttime help with sleeping, it's great, but it's also really important for anybody who works in this field.
Atul Gawande came out with a beautiful book recently, Being Mortal, also was a PBS special that was on television. So people are reading about it, seeing it on television, talking about death and dying, aging, all these topics.
And we also now, if you look across the state, there are these different gatherings for people in our communities the Death Cafe. People are just getting together over meals, which is usually for us a really nice time to break bread with friends and family, and actually having these discussions called Death Cafe or Death Over Dinner. There's a conversation project that is, I know it sounds kind of awful though, doesn't it? It's like, yeah, really, I don't think I'd want to go there. But for those people who kind of, like suddenly, I mean, I get these calls from my friends, honestly, fairly frequently, and they're just like, my mom's got dementia. I have no idea where to even begin with this. And so people who see their family or friends aging and don't know where to go, sometimes the Death Cafe is a place for them to go and engage in these conversations.
And I don't think you guys have one in Juneau yet, right? No. We do have one in Anchorage, and so what that is, it's like about once a month or so, they gather in a coffee shop and have total strangers just get together and gather over coffee and cake or whatever and just talk about all issues related to death. And it's a national movement, so sooner or later, you might have one in Juneau.
So there's also some funding right now for a project called the Conversation Project, which is teaching people how to have these conversations in a public forum. So it's not a healthcare provider necessarily, it's not directed towards us as much as it is the public. And just recently, the New York Times headlines, did anybody see the one on the teenagers making decisions about end-of-life care for themselves? Well, I was amazed. I picked up the New York Times, like, holy cow, right there on the front page. I mean, not only is it difficult, we're talking about our elderly that we think, at some point are going to have these dementia conversations, but as I mentioned earlier, this neonatal population that's now going to be living longer, our teens also are dying of diseases, and we're now trying to empower them to say what they want. And I think that was an incredible story if anybody had an opportunity to read it. And I don't think much of anybody could have seen television or a newspaper or listened to the radio without hearing about Brittany Maynard and her request to die with her view of dignity by moving to Oregon when she had a glioblastoma, and she chose to end her life on her terms. And so I think all of this stuff, it's in the news. You can hardly get around it these days.
So we thought that maybe the best way to explain what palliative care is and what we do and why we do what we do is to tell a story. So this is a story of one of our patients, and the family very graciously gave us permission to share their journey with you. Goli was a beautiful woman in her mid-50s, I believe. Very well traveled, just a very fascinating woman. Happily married, 5 beautiful daughters. Always kind of more healthy oriented person, healthy foods, healthy diet, always healthy. And then I think in 2013, diagnosed with ovarian cancer. Started to see an oncologist, started on chemotherapy. Now the chemo worked on the tumor, but made her really, really, really sick. Diarrhea, nausea, just really, really debilitated. She ended up having a bowel obstruction and ended up in the hospital, delirious, really horrible experience for her and her family. At that time, we became involved, helped symptoms management. She was able to get better, was able to go home. About a year later, she had a recurrence of her cancer. And at that time, it was clear that there was no more talk of a cure. It was clear it was not going to be a cure. But her oncologist said, we can do some more chemo, and it will buy some time, most likely, let's do it. And Goli said, no, she did not want to do any more chemo. Her family was distraught, her oncologist was distraught, and so they were referred to us. And we had a big meeting with the family, all 5 daughters, her husband, Goli, and we started talking. We started out by asking Goli and her family what was their understanding of their illness, of the disease, of the progression, of the treatment. And she was able to tell us really clearly that she knew this was going to be a cancer that was going to end her life, that the chemo might buy her some time, But she was also aware that it was quite likely that the side effects were going to be tremendous again. And she was clear that this was not what she wanted. We were able to get to know her really well. She was a very spiritual person, and her values, her goals were to spend as much time as possible with her daughters and her husband. She wanted to share her memories. She wanted to talk about her faith. She wanted to be with her family the best way she could be. It was a really long meeting. There were lots of tears. And it became very clear that all of her family really shared the same values. Everybody really was on the same wavelength. And Goli's choice to choose quality over quantity of life was really important. And everyone in the family joined in on that choice. And it became clear that she was not giving up, and she was really just giving in, really giving in to the flow. So we ended up seeing, and then Goli was very natural oriented many times and just really had some hesitations with medications, but she agreed that over time that she would allow Linda to work with her on symptoms so that we could keep her comfortable. Over the next few months, we worked with Goli and her family, saw her numerous times, her daughters, different levels of their own grieving experience at losing their mother. As Goli became more sick, she allowed Linda to work with her medications to keep her comfortable, always that fine balance between sedation and comfort. And then there came the time when she no longer could come to the office, and there came the day when we all decided together that it was time to move towards hospice. And the family allowed us to engage hospice. And hospice came in their beautiful way and supported Goli in her goal of staying at home and being comfortable at home. Goli had no more hospitalizations. She was able to stay at home. She was able to spend her time with her family. And in July of last year, she passed, surrounded by her family.
So I think that this is a really good example. This isn't how the choices that everyone would make under these circumstances, and we certainly acknowledge that. Many people would have chosen a different path. In this particular situation, and the reason we brought this up is because Goli was very clear in her mind what she wanted. She made decisions for herself when she was still clear in her mind, when she wasn't really stressed and in the hospital suffering while she was sick or ill. And it was also something that was really in contrast, stark contrast to what her oncologists wanted for her. And so there's a conflict sometimes about what patients want and what physicians think is best for them. And not only did we wind up having to work with Goli and her family, I shouldn't say having to, we loved working with them, they were just a terrific family. But we wound up working a lot with the physician and the provider staff that knew this family so well, because it's very hard for an oncologist to shift and watch a patient elect not to get a treatment that they feel will give them longer life on this earth. So a lot of the work that we do is to support families and patients, but we also support staff when patients shift in ways that is difficult for staff to accept as well. So how is palliative care different? You know, a lot of physicians say, I already do that. I mean, somebody said to me during my fellowship, Linda, really? Why are you doing this fellowship? I already do what you do. Why are you training for this? And I would say probably until I did the fellowship, I thought that I did all this stuff too. So I'll tell you a couple of things that make it different than just being a regular provider. And I think most providers do come to the table with good, compassionate hearts. We do the best that we can. But we see the patients who don't respond as well. Many patients get these diagnoses, they have good interactions with their provider staff, and they don't need palliative care. They have good coping skills, good symptom management, the family's on board, and they go right through their treatment process. But we see the patients that have more difficulty, or the staff is having more difficulty with the patient and family. And what we do that's different from other provider staff or providers or staffs that are working with patients is we work in a team model, an interdisciplinary team model. And we're very blessed in Anchorage to have that variety of people who are skilled in this area. So our team, our interdisciplinary team, consists of physicians, not just me, but other physicians. We have a wonderful social worker and counselor in Diana. We have chaplains who do fabulous spiritual care. We have an ethicist who also sits in our meetings that is really helpful in those times when you're kind of going, wow, I'm not really sure what the right thing to do is here. We've got pharmacists who help us to identify medication interactions and also go, wow, why are you paying, $1,200 a month for this medication when the same medication could be, achieving the same effect for $300? So we really kind of try to hone down the number of medications that people take and the expense of the medications for people, because many of our folks, just as an example, I had a patient who had pancreatic cancer who got a blood clot, which is very common in that kind of cancer. And this person was retired, they were living on their Social Security income, and they needed Lovenox, an injection, and it cost $1,200 a month just for one medication alone. That was their entire savings for the month that they could depend on. How does that work? When one medication that you need to treat a blood clot is all of the savings that you have. Now, as a physician, can I answer that question? I really can't. So I depend on my team. I need a counselor who has experience and wow, can we find a different way to find finances for this person? Can we support them in some other way? Can the pharmacist find this medication or use a different one? Can we get it from Canada? Can we do something to help this family? So it's a team approach, and each person on this team looks at this particular patient and family through their own lens, and then they all have an input so that we have a tailored approach to each patient while we're teaching and training ourselves and patients and families. So it's really a huge help to have a team take a look at a patient in a situation. We also use different language in palliative care. We talk a lot about that. Of course, in Alaska, there's a multitude of languages just to begin with, right? Lots of cultural differences, lots of language differences. But as a physician, I could go through a whole bunch of physician jargon and use lots of big words to tell you, that's about this case and present it. And patients and families have no idea what I just said. And the language is so common to me that I don't even know when I'm using jargon. So we help to do a lot of education for patients, use language that makes sense to them, and make sure that we ask and re-ask and have them tell us what they've learned, what have they heard, what do they understand. So that's a really big difference in approach as well.
And another piece to that language is I think we also help our patients find language to name what they're experiencing, to name some of the emotions that they're going through. And just naming them, recognizing them, validates a lot of what is going on. And that leads into that whole psychosocial component, which is huge for palliative care. If social workers could invent a medical field, we would invent palliative care because it is just so aligned. The cultural piece, hugely important. Alaska, we are so diverse, and I cannot tell you guys how often we get referrals and we hear about a culture or a spiritual orientation. We go, do you know anything about that? And we are pretty clueless. And so what we do is we ask our patients, we ask the families, we ask them to educate us. But we do include the whole realm because it all is part of the patient, of the person that we're treating.
One of the things I think was really interesting to me as you look up here under psychosocial is the spiritual component. I think many of us have our own spiritual beliefs, most of us do of some sort. And I remember when I first started training, I thought, what does a chaplain do? I mean, did they just go and pray with a patient? And I have to say that was my own ignorance. And the chaplain taught me that if you ask across the board for your patients, what is the number one thing that you lean on during the time of such a serious illness? About 82% of the patients will say their faith. Wow. If that's the number one thing your patient's leaning on and you don't address it, then you're not doing your patient the service that they deserve. So I think that it was, again, a really good learning experience for me, that the chaplains who also weigh in on what their patients are telling them, that existential distress that they have, causes a kind of pain that I can't fix with a medication. But our chaplains and our counselors do a great job.
And so probably the biggest component of palliative care, if any, it can be zeroed in on anything, is that we have the whole person and whole family approach. We really try to see the whole person and the whole family. The person in front of us is not the diagnosis, is not the disease. It's a person with a life, with memories, with values. And in our medical care system nowadays, that gets oftentimes forgotten or overlooked out of stress, lack of resources, all kinds of many good reasons, but we feel that this is really important to bring back. So the conversations that we have.
We look at conversations as a procedure, and I can look out here and see some healthcare providers. I see some very familiar faces. Thank you for coming. And as an ER physician, I used to think about the procedure for putting in like a central line, which is a big major IV into a vessel in the central part of the body. And I knew that procedure left, right, and backwards, just with my eyes closed. And I said to a family practice resident last week who called me that was getting ready to go have a difficult conversation, I said, "So what's your plan?" And she was like, "What plan?" I said, "Well, how are you going to approach this family? You want to talk about code status for a patient, and they want everything done, and that doesn't meet the standard of medical care. So you want to do one thing, they want to do another one. How do you think you're going to get there?" You know? And they were like, I don't know. So there's actually a procedure. There's a process that we can go through and walk providers through how to get where you think you need to go with the family. So we really look at conversations as a procedure, a structure, something you plan for. You don't just off the cuff start saying what comes to mind. These conversations also take a lot of time, as you can imagine. This is not something that's a 15-minute visit. This is something that often on our first visits, we block 1.5 hours to 2 hours for an initial intake visit. Follow-up visits are often about an hour, and it takes probably 4 to 5 visits often in the outpatient setting to get to an area where we can even begin to have these really in-depth discussions. In the hospital, first time we do is about 1 hour to 1.5 hours, and followed up often by hour-long conversations there as well. So it's very time-consuming. So when we talk about palliative care, we actually are given right now the time to do those. That's a big difference from many, many other clinician practices. We also, thanks to Diana, I've learned how to do some listening for a change. Physicians aren't very good listeners. We're used to talking a lot. And so this has been a real challenge for me to sit back and listen. And I don't just mean listen, I mean hear. I mean turn my pager off, turn everything else off, be present in the room with the patient and the family, and nothing else on my mind. It's a big change. Active listening is difficult, and it takes a lot of energy to do it.
It's a difficult one.
All right, this is the difficult learning slide. So I can't really point at it too well. What I wanted to talk about was, this is the other question we often get asked is, how is palliative care different than hospice? I frequently get the question from people who don't think they're going to like palliative care, aren't you just hospice in disguise? You know? And so the answer is no, we really aren't hospice in disguise, although palliative care is really an approach to medicine to help with symptoms, and that should be all across the spectrum of care. So on the left side of this slide, where it's yellow, most yellow, that's at the time of diagnosis. And usually a patient and family get that diagnosis at that time. And notice that palliative care usually doesn't kick in at that time. If the patient and family are coping or trying to cope well, we won't see them. If they're not coping well or having difficulty with the diagnosis or treatments, then palliative care is asked to step in. That's where the blue part comes in. At that time, you can see there's this little blip where palliative care becomes actively involved, and we're working with the patient and the family, and if we do our job well, then we should see a little drop. You shouldn't need our services very much. But as the disease or illness continues to progress, so do symptoms, and so does the distress of the family, and so we're usually invited in again and more intensive. And as the whole disease progresses, our involvement increases throughout the course of their care. As that goes almost completely blue, you can see there's a little blue box that says hospice. And hospice comes in as a benefit that everybody has paid for with your tax dollars for the last 6 months of life. I think, I'm not sure in Anchorage or in Alaska now, but I think nationwide, most people are on hospice services for an average of 21 days. 21 days. People engage at the very last moment, and then they think, well, hospice just came in and helped us to die. Well, people were already at the doorstep, and then they invite hospice in when they can't think of anything else. But I would say hospice is a benefit that you've paid for 6 months. Engage them, and if you're still around in 6 months, then re-engage, and they'll just reevaluate you, and you just stay. If you get well in 3 months, you can sign off of hospice. It's terrific. I mean, it's a great support system for patients who may have 6 months of life left or not.
And I also want to add in there that even though we are not hospice, we are like sisters. We couldn't do the work we do without hospice. True. And I want to out right now our friend Allie O'Donnell over there with Hospice of Anchorage, and just as one of the just wonderful support. We work together on so many ways with so many patients.
And we blend over. So that's a good example, actually, that palliative care continues on through hospice. And whenever I can, I try to stay on as a primary attending for patients that I've been caring for years during their hospice care, if I'm able to do that for them. So palliative care crosses the spectrum. But be very clear that palliative care alone does not mean that you have a life-ending illness. Many patients that we have are cured, and they go on to live long, happy lives. Okay? We're simply there to help them through that adjustment period. But many of our patients do have life-limiting illnesses. Some of their cancers will take their lives. Their heart disease, their lung disease, their kidney disease will take their lives. But it's also been pretty clear that with many types of cancer, that we are able to extend people's lives with the addition of palliative care. And there's some pretty good literature out there right now, especially with lung cancers, that we can at least add several months of quality life for patients.
So Alaska, of course, as we all know, you guys probably even better than me in Anchorage, is very different. We have different circumstances than the rest of the United States. Most of our people, only 50% of our population lives in the city. Our situation in Anchorage is much less complicated than what you guys deal with on a daily basis, being more remote. Hospice services are limited. We have 4 Medicare-regulated hospices, I think, in the state of Alaska, and then many wonderful volunteer organizations. We're very multicultural, and we have a lot of people who are getting older. Of course, we're not included, but all the other ones are getting older.
Well, actually, the statistics for the Census Bureau for Alaska shows that we're actually aging faster than any other state in the country. Any other state in the country. So if you look at these numbers, 76,000 now, and in 2025, in 10 years, double that amount, 150,000 patients over the age of 65. Okay. So our hope is to help educate others for primary palliative care. When we're board certified and trained, that's called specialty palliative care or tertiary palliative care. We recognize that in the state of Alaska, in our huge state, there's about a half dozen physicians who are board certified and trained in hospice and palliative care. There's many other nurse practitioners, and by many I mean a dozen maybe, and counselors are now being trained more and more. And our hope, especially with weekends like this, thank you very much for inviting us here, is to improve the growth and education of palliative care services across our state, and to provide resources for those people who are interested in this kind of medicine. And hopefully, we have a little question mark about telemedicine. This is something that may be coming up in the future that we're beginning now to develop to try to reach out to those more remote communities that we know will never be able to have providers with specialty care in their community. But maybe we'll be able to reach their providers or those patients through telemedicine, hopefully in the near future.
So, how can we make this all more pleasant? Really important. We just want to encourage everybody who has not done the advanced directives to seek out information, make your wishes known. It's a way to be in charge and to speak up and have a voice and be empowered. And amazingly, once it is, even just this document of the advanced healthcare directives, once that is completed, there's such a sense of relief for ourselves and for our families.
So, thank you all very much for listening. We're also happy to entertain any questions, and they've asked us to help direct you to the microphone so it can be recorded if you have a question. So I see someone picking up cards, but go ahead, please.
Hi. I would like to ask what your advice would be to a patient who has an oncologist who's aggressive and continues to want to treat and not really talk about the alternative of palliative care and hospice care. How would you advise, what would you advise to the patient and their family?
It's a good question. It's a great question, and we get asked that one an awful lot. And what I would say is, again, going back to the slide before this, is learning that having a voice with your physician is really imperative. I think we're going to get better at it in a couple of years, but actually letting your physician know, this isn't acceptable to me to have this quality of life. What I perceive to be quality of life may not be what Deanna thinks it is. And so as a patient, what you believe to be quality of life may not be what your physician believes is quality of life. And so what I find a lot is that patients, even when they're getting chemotherapy and they're very dissatisfied with the side effects, even with good treatment, is they're afraid to tell their physician that they don't want to go on anymore. They're afraid they want to be a good patient. They want to please their physician. And what I would say is you can do that. I would say to patients, letting your physician know that quality over quantity is important to you, and quality of having nausea, vomiting, or being too weak to spend quality time with your family is not acceptable to you. And you can say no to a doctor. You can. I know it seems weird, but you absolutely can, and I think this is part of the being empowered to have a voice and make those directives known. Anything else? Thank you for your question.
You mentioned cost of services. Are your services, both yours as a doctor and a social worker, paid by insurance or government programs?
So we are paid by insurance right now. The way that our program is set up for us is that for right now we are employed by the hospital, and the hospital pays us a set salary. But I will also say that there's not a big push to hire and train a lot of palliative care providers because the reimbursement's pretty terrible. Most patients, by the time they see us, are financially devastated with their illness, and the cost, out-of-pocket cost, they don't have any money, so they're primarily on Medicare and Medicaid, which the reimbursement is not that great. So, and as you can see, the time commitment is huge. So it actually is a service line. So it's not like cardiology where I can bill pretty heftily for the things that I would do. It's really low reimbursement for a lot of time. But the quality piece and the reason that people keep coming back and the downstream effects of people getting what they want, the word is beginning to spread. And then 3 months of opening an outpatient clinic, I went completely full. 3 months. Yeah. So.
And hopefully this is all part of a shift of culture, and hopefully our healthcare system returns to some sense of saner view of the human being.
How would a family sign up for palliative care when a member is elderly and unhealthy but not clearly dying?
That's actually the best time to sign up. Because as I said before, that's sort of the prime time when the person may not be actively dying, but you can see kind of the writings on the wall that things will be coming down the road. And the idea is to have these discussions when patients still have as clear a mind as possible and when it's not a crisis situation. Families in crisis, as you well know, don't act the same as they do when things are pretty easy. So just signing up, ask your physician. We have a couple of things that we brought. Signing up may be as easy as signing up to get this book, Hard Choices for Loving People. I didn't write this book, not mine. But it's a terrific book that walks you through those choices. If there aren't palliative care physicians or providers in your community, they're welcome to contact us and we'll do our best to walk them through the process. But they can simply start having the conversations through a simple book like this that says, wow, what are those choices that might be ahead for me?
You had mentioned that Medicare or some insurances cover hospice. If it's palliative care, is it covered by insurance or including Medicare?
So the answer is yes, it is covered. Reimbursement's not huge, but it is covered, and that's a great thing for people to do. So if you're in an area that has palliative care and you think you might need it for you or your family, just call and sign up. We'll be happy to see you.
And I might also, Anchorage we are blessed because we are bigger and we have specialized palliative care services. Many places do not, but I think amongst the primary care providers there is such a huge interest to be more palliative, and to, even if they might not be the specialty palliative care physician, to implement the skill set and to implement the attitude and implement all of that into their praxis. And it's our hope that through this it will spread and continue to spread.
There's also a list of resources. I just want to let folks know that we put some online resources out here for people to access. Some physicians and mid-level providers don't know about palliative care, haven't had the opportunity to be trained or educated enough in that area yet. So there's a lot of online resources available for people to access on their own or to direct their providers towards. So there is hope out there, even if you don't have palliative providers in your community. The internet tells all. So, all right.
Can you talk about the difference in palliative care after a person with dementia or for a person with dementia, which can be a long progressive disease?
Do you want to talk about that?
One, we have a lot of patients and families where a patient with dementia is our patient. And so what really becomes important for us as providers is to get an idea about who is this person, who is your mom. Your mom, right now, she cannot tell us anything about what's important to her, but you can tell us. And so we gather the family, we try to get an idea about who is this person, what's important to her, what is her quality of life, what is her line in the sand. Is she a person, would she want to have a feeding tube if she can no longer eat? Would that be her quality of life? What is it that matters to her? So that then her healthcare team can make decisions based on her values, her goals. And even though a patient with dementia might not be able to communicate those goals to us, her family can, her loved ones can. And it's our job to make sure that they get honored.
Okay. What can we do as a community to assist in meeting the need for palliative care?
So, well, I think you're in a great starting place. Actually, I think the End of Life Care Foundation is really being very proactive. And just simply tomorrow, I think we've got about 35 folks from this area that are signed up to learn about palliative care. And I think that trickle-down effect, we hope, is going to be just tremendous. And you'll start to see it and feel it within your community. The other thing we alluded to earlier is, as dicey as it might feel to step out there and think about doing a death cafe or having the conversation. Those kinds of things, once they get started, they sort of get a momentum of their own. And it gets a lot less scary to talk about this stuff. And so I think there's lots of things that you can do, and I think this kind of talk is a great segue into getting started on that.
Well, I'm curious, you spoke to the difference between palliative care and hospice, but with the emergence of palliative care over a decade, has it changed the role hospice plays in the way they're seeing people come into hospice? Has it changed the job in any way for them?
Do you want to tackle that? No. So I think we're still seeing the change. Right now what I see is that we have a transition right now where patients are more smoothly transitioning into hospice. I think that we can debunk, if that's a fair enough word to use, the fears of hospice. I think, as I mentioned earlier, people see hospice as sort of ushering them out the door off this planet or into the next life. And I think after actually having discussions about truly what hospice can offer families, I see a much smoother transition, sometimes earlier. And we're talking about having 24-hour support once you're on hospice. And we can't offer that in palliative care. So I think just little tidbits of information has really helped a lot. So I think the hospice will hopefully improve for length of stay.
Just wondering about the mental health component. Do you have specific providers as part of the team to work with issues of depression and anxiety?
Hey, now you can get me going for half an hour.
I know,
So
but I'm also seeing somebody back here waving me down to
all
1
right,
minute.
good. Okay, so I'll try to keep it short. So one big piece that's very important, I think, for all of mental health providers to learn is that patients who experience life-altering illness are not folks who have mental health issues. They're absolutely normal people of all walks of life, and experiencing severe emotional reactions is normal and is to be respected and expected. So instead of seeing a patient in front of you who trying to diagnose them with depression or anxiety, really looking at what is it that they're going through, and then helping them identify those feelings, validate the feelings, process through them, and really helping folks identify their coping skills, knowing that most folks have coping skills and have a great inner sources of strengths, and our job is to assist them. And just throwing on to that, mental health is not really a separate piece in palliative care. Linda does in her sessions as much mental health as medical. It's combined. As it is a whole person, we can't dissect them. So we all work as a team, and it is all that whole person and whole family perspective.
Taking cues from the back. I think. Okay.
Nice job. We'd like to thank Dr. Smith and Ms. Seropian for joining us, and we thank you for watching everything you want to know about palliative care but were afraid to ask. And for more information on palliative care, please visit our website at foundationforendoflifecare.org, or you can like us on Facebook so you can share this program with others. Thank you so much, and take care.